Okay. Do you want me to?
So, yeah.
So I'm going to share my slides again. Oops.
So I'll just give some small introduction. Good evening, everybody, and a very warm welcome. Today, this is the first session of the new team of PHOIP team, and with me and Dr. Satya, we have Dr. Pawni and Dr. Arun Daneva, who is going to coordinate international webinars. So they are very well-known PHO faces, and we are very glad that we are able to bring very interesting webinar today on HPLC. As you all know, HPLC is the most frequently ordered investigation in pediatric hematology practice, but it is one of the most often misinterpreted tests also. So today we have the privilege of having the two exceptional authorities who bring global as well as national perspective to this topic. The topic of today's session is HPLC in hemoglobinopathies beyond the report, and we are going to learn a lot today and looking forward to it. I would request Dr. Pony to introduce our today's speaker, Dr. Jane Hankins from St. Jude's Children's Hospital. Dr. Pony, please take over.
Thank you so much. I'm sorry, my video is not visible, but it will eventually appear. But thank you everyone for joining. Good evening to everybody who's joined us today. We're extremely delighted to welcome each one of you to this webinar on HPLC interpretation. As Dr. Shweta had mentioned, we've got two very good speakers. One of them is Dr. Anita Nadkarni. We're just waiting for her to join. In the meantime, I would like to introduce Professor Jane Hankins from St. Jude's, who is delivering the talk today. She is a pediatric hematologist from St. Jude's Children's Research Hospital. She's also the director of St. Jude's Global Hematology Program. She's very, very well known for her clinical and research work, mainly focusing on sickle cell disease and implementation of evidence-based therapies and longitudinal cohorts, such as CRIP, with a particular emphasis on how lab markers, including HPLC and quantitative measures, will translate to treatment decisions. I would just give a brief introduction of Dr. Anita as well while she's joining. I don't think she's joined yet. But we all know Dr. Anita Nadkarni, who's a senior scientist. She's the director grade. She's based at Hematogenetics, Department of Hematogenetics at the ICMR, National Institute of Immunohematology at Mumbai. She's got more than 3 decades of experience in the molecular genetics of hemoglobinopathies. So we've got two wonderful speakers who could deliver the apt talk for us and enlighten us about HPLC. She's also done extensive work in thalassemia and sickle cell disease and has lots of publications, more than 150. Without any delay, probably we can start the talk. Professor Jane Hankins, over to you, madam.
Thank you, Dr. Pony. Thank you, Dr. Shweta, for the invitation to speak today. My name is Jane Hankins. I direct the Global Hematology Program at St. Jude Children's Research Hospital in Memphis, Tennessee, in the United States. I am going to speak today about interpreting the results of HPLC. That's the most commonly used fractionation study for hemoglobins in the United States and also throughout the world. And before I begin, I would like to start with a case, a 17-year-old male who is a real case, was one of my patients. He was previously healthy, had absolutely no problems, went to a community event where free sickle cell disease test was being offered, and him and his brother and his father were at this fair and wanted to get tested. He was a premature child, born at 7 months of age. He spent 4 months in the NICU, and he weighed only 1 kilogram. Had a tracheostomy, colonoscopy, had several complications and surgeries, and was transfused, the father thinks, when he was born. Likely he was, given the number of complications. And then his brother, twin brother, also an African-American, 17 years old, also healthy, was at this fair with his brother and his dad, and also wanted to get tested. Similar story, 7 months. He had fewer complications. He weighed 1.2 kilograms and also had asthma, never had a transfusion, according to his father. So this is what the HPLC showed when they got tested at this community health fair. They both had no hemoglobin A, and they had about 65% of sickle hemoglobin. The hemoglobin A2 was normal at 2.4, 2.5%, and the fetal hemoglobin was elevated, and other hemoglobin was identified too. So they were, of course, referred to us. They were referred as having sickle cell disease. So I want to ask, you can put on the chat what you think these siblings have, these twin siblings. SS with high F, sickle cell trait, hereditary persistence of fetal hemoglobin, sickle cell with hereditary persistence of sickle hemoglobin called SHPFH, or I really don't know. And that's okay. I'll just give you 1 second. All right, so I will go back, just put on the chat what you think, and I will come back to this case in the end because this is a very interesting case. All right, so the father was at the fair too, and we also tested the father, and he had hemoglobin A. He had plenty of hemoglobin A. He had no sickle hemoglobin, he had normal hemoglobin A2, and he himself had 14% of hemoglobin F. The mother was not available for testing, but the father said, I think my ex-wife, because they weren't married anymore, I think my ex-wife has sickle cell trait. And these are the CBCs of the two siblings. The hemoglobin was 13 for both. The MCV was a little bit decreased. Remember, they're 17. They should have an MCV of an adult. They were slightly decreased. The RDW was high, 19%. The bilirubin was a little bit elevated. This was all indirect bilirubin. And the reticulocytes were increased. So they did have some degree of hemolysis. So despite the normal hemoglobin, they were well compensated with slightly elevated reticulocytes. So these are two persons with no symptoms, but did have some degree of hemolysis, which means they did have something. All right. I didn't have blood smears from them, but if I did, they would look like this. Small red cells, microcytosis with some target cells. This is what the red blood cell looked like when I looked under the microscope. All right, now what you think they have? Sickle cell trait, now that I gave you more information. Hemoglobin SS with high F, hereditary persistence of fetal hemoglobin, hemoglobin S, HPFH, or something else. Okay, everybody thinks he has sickle cell trait. Or some people say sickle cell trait, some people SHPFH, some people HPFH. Okay, there are a lot of people saying SHPFH. This is a good guess, SHPFH, and this is what I thought he had, but the fact that he had hemolysis made me think that that's strange. Usually you don't have hemolysis with SHPFH. So let's dive into these two cases. So this is what I was thinking at the time, and I did do more tests on him. I'm going to come back to this case at the very end. So I think it's not sickle cell trait because they didn't have hemoglobin A. The clinical presentation less likely as with high F because they don't have any symptoms. No, they are 17, never had any pain, any other problems. Now that it's unlikely, not impossible. The HPFH is not because they had asked. So SHPFH was my guess, but the high retics and high indirect bilirubin made me think there might be something else. All right, so keep this case in your mind. We'll come back to it. Oh, I'm sorry. Actually, I do have the results. So I did a DNA test, and both of them have something different than SHPFH. They had hemoglobin S with gamma delta beta thalassemia. So this is a very rare form of sickle cell disease with symptoms not as bad as hemoglobin SS, for example. And I will come back to this case in the end because we did a lot more studies to understand this condition better. But before that, I'm going to talk about the types of hemoglobin very briefly, and then we'll dive into the methods to quantify hemoglobin. We'll talk about HPFH and how we interpret those results. Oh, so very quickly, sorry for the title here. So what a hemoglobin is, I think I don't need to say much. It is a quaternary protein with 4 globins, 2 betas, 2 alphas in the case of hemoglobin A, with the beta globins produced in the chromosome 11 and the alpha globins produced in the chromosome 16. And this is where the genes are located. On the chromosome 11, we have 2 copies of the globin genes. We call them HBG. We have the gamma G and the gamma A. And then in the same chromosome, we have the delta and the beta globins, the genes that produce the delta and the beta globins, HBD and HBB. HBB are the beta globin. And on the chromosome 16, then we have the alpha globin genes. We have 2, alpha 1 and alpha 2. We call HBA, HBA2, HBA1. All right, so this is just a depiction of what the hemoglobin assembling looks like. Each globin with a heme group where the iron and the oxygen CO2 are carried. Very good. So we have 2 types, just very briefly, the kinds of hemoglobin disorders that exist, qualitative and quantitative. Qualitative are abnormal globin chains. That is the case of sickle cell disease or hemoglobin C disease, hemoglobin E, hemoglobin D. And those are directly identified by separation techniques, such as isoelectric focusing, high performance liquid chromatography or HPLC, also electrophoresis. The quantitative ones are the thalassemia syndromes. Those are normal globins, but the production is abnormal for one of them. So there's this imbalance. If you produce less A, then you have too much beta. If you produce less beta, you have too much alpha. And then you have deletional kinds that you delete the gene, and so the production drops, or in the non-deletional ones, the mutations, then functionally they are quantification, the quantity is decreased because they are non-functional. The interesting thing is you don't measure this, you inferred by separation techniques. So it's a little bit different than directly measure an abnormal hemoglobin versus you infer that there's decreased production by doing the quantification of the hemoglobins. All right, so which kinds of tests do we have to diagnose hemoglobinopathies and quantitative hemoglobin disorders, right? Qualitative and quantitative. So we have biochemical methods such as electrophoresis. We have cellulose acetate, acid agarose. I'll talk about them. And those are separation by electrophoretic mobility on the gel. And then you can quantify the abundance and proportion of them relative to each other. And then we have functional differences in the hemoglobin. One that is very used is the solubility test for hemoglobin. It's called SickleDex. It's the cheapest one, also the one with the most problems because it's very easy to do. It's very cheap, but also doesn't tell you much. It cannot tell you if a person has sickle cell trait or sickle cell disease, for example, much less the type of sickle cell disease that you have. So it's a problem. Oxygen affinity does not tell you the diagnosis, just it can catch unstable hemoglobins, for example, that have too much or too little oxygen affinity, and that in those cases you can have a lot of, you have hemolysis, and that's not what I'm going to cover today. And then we have the DNA-based methods, multiplex PCRs, reverse dop genotyping, DNA sequence that give you the definitive diagnosis. Also more expensive to do and demand a different level of complexity in the lab. All right, so here's the SickleDex that I mentioned before. It's a solubility test, very easy to do. You can do at the point of care. And what you do is you break down the hemoglobins in the solution, and then you put the tube against this card with the lines. And if you cannot see the lines behind the tube, then you say there's sickle hemoglobin present. If you can see the lines through the tube, then you say there's not sickle hemoglobin. This doesn't tell you much, just tells you there's sickle hemoglobin here, but you can really tell if this is trait or disease. So I find this test not helpful, and I wish people would stop using it, but a lot of people do, and I think sometimes it creates more problems than it helps. And I think we have better tests today that can substitute this test. Then this is just an example, the hemoglobin electrophoresis with cellulose acetate, which is more, with a higher pH, and agarose gel with a lower pH. This was the original way that we had to diagnose abnormal hemoglobins. We don't do a whole lot of these today anymore. And the way we did that was just a gel electrophoresis. So we distinguished the types of hemoglobins by the patterns that they ran in the gel. So then we defined, the bands, which is specific hemoglobins. And then you can see here that certain hemoglobins run together. So depending on the gel, which also creates confusions because there's superposition of the hemoglobin. So here's the example of the cellulose acetate and acid agarose. You have sickle cell trait, AS. Here's how the pattern of running in the gel varies depending on the pH, the type of gel that you use. But then you have, but then you have hemoglobins that run together. For example, S and D can run together, so you cannot distinguish. So if you run both types of gels and you compare, then you can tell, for example, that let's see, line 2, for example. This is AC here and AC here, and because it runs with D, but then you compare. Here's what it was AC, and then here it has to be AC, cannot be AD. So you can give the diagnosis of hemoglobin C trait. But we have tests that are a little bit easier today. Isoelectric focusing is another one that we can use. Also demands having specialized labs. You have sharper bands, better separation on some variants, D and G, for example. So sometimes it takes 2 tests. You have to confirm with a different kind of technique, and then you compare both results, and then you can tell, okay, this is what you have compared to both tests. And then the HPLC, which is the most used, and I find it a little bit easier to interpret, but sometimes you do have superposition of hemoglobins that run in the same pattern, so you have to do a different technique. But this is probably the one that we use the most and most established. And then I think what we're doing today is the hemoglobins that are uncertain here, we are confirming with DNA testing, which are becoming cheaper and cheaper to do. But this is an example of a patient with, here we go, a little bit of F, a little bit of A2, there's no A, S, so this is a patient with a hemoglobin SS. But then let's see another case here, just comparing what the gel would look like and the HPLC will look like. So this is a person with sickle cell trait, so hemoglobin AS. So on the gel, we compare with the normal control, and the sickle cell trait has A in the band, the pattern of A, and then the S, there's nothing here in the normal, so we give the diagnosis of AS. And if you look at the result, HPLC, it's easier to see. You have 2 peaks. The peak with A see how is wider, so there's more hemoglobin A than hemoglobin S, and it quantifies for you, which is, I think, is the most useful part of HPLC. It gives you the relative percentage of hemoglobin A relative to S, and the F and A relative to all the other hemoglobins. And then remember, hemoglobin has to add to 100%, so we have the relative percentage of all the hemoglobins inside the red cells on average. So anyway, it's a chromatography technique, and this is the most used one. So this is a sickle cell trait. And then we have the newer tests, the rapid diagnostic tests, which have been developed in during this decade, so less than the 10 years ago, and their use is really, really high. I know that India has its own rapid diagnostic test. I'm going to show an example of 3, but I know that you guys have your own and you don't use any of these 3. So the first one is the sickle scan. And the sickle scan is shown here. It's very easy to do. It's just like doing a COVID test, except for you use blood and not nasal swab. And so you use a drop of 0.05 microliters of blood, and you put it here, and then you get the result on a cartridge. It has very high sensitivity and specificity. The problem that I see with this test is that has not been cheap. Some countries are paying $8 per test, $8 per test. That's a lot. And then the second one is hemotype SC, and it's also with high sensitivity specificity. A little bit harder to do. You have to do you use a drop of blood, 0.05 microliters, and then you mix with a solution that comes with the kit, and then you shake, and then you dip the strip and wait 10 minutes, and then you get the results, which are reversed from sickle with sickle scan. So the bands, they read a little bit, they read opposite. When you don't have a band, that's when you have the abnormal hemoglobin. So it just takes a little bit of adjustment to learn how to interpret the results of the hemotype SC, but it is the cheapest one of all. Because if you negotiate and buy a large amount, you can get it for $1 per test. Still expensive to do mass testing, but it is much better than $8 a test. And the last one depends on this machine. It's called the Gazelle diagnostic device. This is the picture of the machine. The machine itself is not expensive. I think people are buying for like $2,000. And in the test, a little bit more involved. Here's showing you get the solution, and you put in a cartridge, and you put the blood, and then you centrifuge. It's a mini centrifuge, and then you wait, and then you put the machine, and it gives you the results. I think the biggest advantage of the Gazelle is that it gives you the percent hemoglobin, just like HPLC gives you the percentage of each hemoglobin. It gives you the percentage. You store in the machine, then you can upload the results into your database or into the cloud. So the advantage is that it can go straight into national databases, for example, if you're doing newborn screening, mass newborn screening at the country level. And it can diagnose thalassemia too. So that's something that the other two rapid diagnostic tests cannot do. And they are now also adding the advantage of being able to diagnose malaria. And I heard that they were also adding the iron deficiency anemia. So I think this has multiple functions. So I like this, but I don't think it's at the point of care. It needs to have at least some kind of lab to run the Gazelle. But in general, combined, these three rapid diagnostic tests have pretty high sensitivity and specificity. This is a meta-analysis done, pulled data from several studies that show specificity is excellent. You really don't assign a case of sickle cell disease SS specifically if you don't have it. So you're pretty confident saying that you do not have sickle cell disease. But you can, there are some cases that you could miss. The sensitivity is not quite 100%, but it's pretty high, over 95%. So people are starting to use these RDTs for newborn screening. And again, you cannot diagnose thalassemia with those first two, but with Gazelle you can. And people are starting to use like at the point of care, distant areas, rural areas. So there's big advantage with them. All right, so let's now talk about how we understand and interpret results of HPLC, so the fractionation of hemoglobin tests. So I'm going to ask another question here. What hemoglobins are present in an adult without any hemoglobinopathy and without thalassemia? Hemoglobin A, H2, F, hemoglobin B, or answers 1, 2, and 3 are correct. Right. So answer is E. That is correct. There's no such a thing as hemoglobin B. I always put this here because I've heard so many times people telling me hemoglobin B, there's no such a thing as hemoglobin B. So you have hemoglobin A, H2, and F, and that's correct. So just very briefly, you've seen this picture before. This is the globin synthesis during prenatal, neonatal, and after birth, periods in life. So the gamma globin is produced pretty early in the first trimester, is high throughout pregnancy, and shuts down. The production shuts down immediately before birth. And then after birth, you see this sharp decline in the fetal hemoglobin production. Then you have the embryonic hemoglobins that are produced in the yolk sac, and they disappear in the first trimester. And then you have the beta globin that begins in the first trimester and goes up, and after birth, it has this sharp increase, and the alpha globins produced throughout pregnancy and throughout life. And then you have the delta chains, the delta globins that are not produced until after birth. And you never have a great production of delta globin throughout life. They're there, and it's very little. The thought is thousands of years ago, we did produce a lot of delta globins. It's the thinking is that the production, it probably had some function in the human race in the past, but with evolution, this delta globin production became unnecessary, so it's progressively shutting down. The thinking is that eventually it will completely disappear, that we wouldn't produce gamma globin, delta globins anymore. But we still do, and we still produce a little bit. And then for this is just for illustration, fetal hemoglobin is alpha and gamma globin. Just to understand, because I'm going to talk about the percentage of hemoglobins very soon, but just to memorize fetal hemoglobin alpha and gamma globin binding together, hemoglobin A alpha and beta, and then hemoglobin A2 is delta and alpha. All right, so this is a very simplified illustration, and I use that for teaching purposes. Where are the globin genes? And I'm going to use this picture over and over to help us interpret when we look at the percentages of hemoglobins. So this is just an illustration of where the embryonic hemoglobins are in the chromosome 11. This is the epsilon, and then 2 gammas, 1 delta, 1 beta. And this is per chromosome, right? So on the chromosome 11. And this is the direction of developmental time from embryo to adult. So I flipped this. In reality, it's the 3 is here, 5 is here. So it's from beta to gamma. I'm sorry, I forget what I said. So this is the developmental time. We begin, we produce the embryonic and you shut down, then you produce the gammas and you shut down, and then you have the delta and the beta being produced as an adult. And then the chromosome 16, different chromosome, then you have the zeta, which are embryonic, and same thing, it turns on and turns off, and then you turn off the production of alpha globin throughout your pregnancy and throughout your life. All right. So now, again, the types of hemoglobins, we have the embryonic hemoglobins that are produced in the yolk sac, and they disappear after the first trimester. You have GARO 1, zeta 2, epsilon 2, and GARO 2, alpha 2, epsilon 2. So this is just early on and they go away. And then you have hemoglobin A, A2, and F that persist throughout life. Very good. So now we're just putting it together. Chromosome 11, chromosome 16, gamma throughout beta, and then alpha, zeta. So you have now the percentages. A person with no thalassemia, no sickle cell disease, no hemoglobinopathy will have about 96, 97% of hemoglobin A, A2, and beta 2. Less than 3.5% always of hemoglobin A2, so alpha 2, delta 2, and then 1 to 2% of hemoglobin F, A2, gamma 2. So this is what a normal adult would look like. And we'll go back to when this person was born in the newborn screening, which typically we do for second day of life, when you still have a lot of fetal hemoglobin. So you have a bunch of fetal hemoglobin, 80, 90% of alpha 2, gamma 2. Then you have no hemoglobin A2. Remember, you don't produce A2 until after birth, so it's 0. And then hemoglobin A will be the difference. This is all relative. Remember, I said you always add up to 100%. This has to add to 100%. This has to add to 100%. So the difference of fetal hemoglobin in a normal person will be 10 to 20% of hemoglobin A. Right? So then this is what a normal person will look like. And most labs would not give you the percentages. They will if you ask, but normally they just give you the letter. Oops, sorry. Oh, normally they just give you the letter. So the way to interpret is hemoglobin F, meaning the letter that appears first, the highest quantity, so fetal hemoglobin, and second will be the one second most common, hemoglobin FA. All right. So now let's start creating problems and giving mutations and deletions to those globin genes. So where is the globin gene for the sickle mutation? Gamma, alpha, beta, delta, or epsilon? Right. It is the beta globin. All right, so let's show it. Let's look now. Now, same picture, simplified diagram where your genes are. I didn't talk about this LCR, the locus control region, and this is just a representation. This is not really what it looks like, but it's just to understand the locus control region controls the function of these genes. This is important to know because you can have mutations here that shut on or shut down the production of the globins. All right, so now this person has the beta globin mutation for sickle cell disease in one copy of the beta globin genes. So now this person will produce hemoglobin. As an adult, this person is going to produce hemoglobin A2, yes. Beta, alpha, hemoglobin A2. This person will produce fetal hemoglobin, alpha with gamma. This person is going to produce hemoglobin A because this joins with this. And this person will also produce something different, which will be when alpha joins with beta S, it will produce alpha 2, beta S2. Now look at the percentages, how interesting. I teach this because it's important for interpretation of results that will look a little bit different in a little bit, you will see. So look at this, 50% of your beta globins are normal, 50% of your beta globins are mutated. Why isn't the percentage split even? Why don't you have 50% of A and 50% of S? Why there's also always this imbalance? You have more A than S in this case. That is because nature is wise. Every time alpha globin is produced, it's going to look around and prefer to bind a normal beta than a mutated beta. So there's this increased affinity for a normal globin than a mutated globin. And that's why you always have this imbalance. There will always be more A than S in this case if you have one copy of each. So this is sickle cell trait, hemoglobin AS. As a baby, in a newborn screening, you are going to make hemoglobin A, you are going to make this special hemoglobin, sickle hemoglobin, and you're also going to have the same proportion. This is split, more A than S. At least 2% difference, sometimes 3% difference between one and the other. And the difference will be hemoglobin F and no hemoglobin A2 because you don't produce hemoglobin A2 until after birth. Then the letters will be hemoglobin FAS. More F than A, more A than S. Hemoglobin FAS is sickle cell trait. All right, now we're going to give mutation for the sickle hemoglobin in both copies of the beta globin. Now, as an adult, this person is not going to make any hemoglobin A, zero hemoglobin A. There will be some hemoglobin A2, less than 3.5%, fetal hemoglobin 5.9. Now, fetal hemoglobin is a little bit higher. Why is that? Again, nature is wise. Nature looks and says, okay, both copies are mutated. Let me help, and retains some of the production of the gamma globin. So it doesn't shut down completely after birth. That's why you still have 5 to 9%. And then you have the rest to 100%, has to add up to 100%. You have 90% of sickle hemoglobin. This is sickle cell anemia, hemoglobin SS homozygous. And as a newborn screening, this person has no A, no A2, and then the difference will be F, the majority F, and 10 to 20% of hemoglobin S. And this is going to be hemoglobin AFS. Hemoglobin FS, sickle cell anemia. There are other things that give you hemoglobin FS, but in this case, it will be FS from hemoglobin SS homozygous. All right, now let's mix a little bit. You should know this question because you have a lot of beta thalassemia major. So which globin gene is affecting beta thalassemia major and how many alleles are missing? Correct. So you have only 2 alleles. You cannot miss 3 beta globins because it's in a beta globin because it's a beta thalassemia major. and you only have two alleles, so you can only miss those two, right? So this is what it looks like. So beta thalassemia major, you have nothing because both are gone, and then both are silenced. Usually a mutation that silences the beta globin gene. And now as an adult, you have no hemoglobin A being produced. Hemoglobin A2 is very low, but this person will need blood transfusions to survive, right? So in a newborn screening, you will see 100% fetal hemoglobin. There's nothing else. There's no fecal hemoglobin. There's no hemoglobin A2 at birth. So every time you see fetal hemoglobin 100% at birth, even though there are other things that can cause it, you cannot wait. This is HIF beta thal major until proven otherwise. This person needs a referral to a specialized center to begin blood transfusions. And this is what the blood looks like. And this is something that I know is very, very common in India, not as common in the United States, but this is what the blood looks like. So here, because we don't have as many beta thal majors, sometimes if you see a thal intermediate, and we see a smear that looks like this, people say, oh, it's iron deficiency anemia. So that's how not having that many cases here causes the confusion. But it's normal smear, right? A lot of poikilocytosis, a lot of hypochromia. All right, and beta thal minor is when you have one copy of the beta globin that doesn't work, but you have a normal one that works. And what happens in that case is that nature-wise, again, the delta globin, which doesn't work very much, we never produce much delta globin. Now you have retained function of the delta globin. Now you have, as an adult, hemoglobin A, 85, 90%, a little bit less than people doubted, because now you have more A2 and you have more F. And the F, also the gamma globin is elevated. So every time you have no production here, or then you have this turned on and this retains a little bit of production. In the other condition, then in the other situation, which is also a beta thal minor, is that you have decreased but not absent production of the beta globin. So this is just a different type of mutation that, again, you turn on the delta globin production, but you have the same number. So you really, by looking at the HPLC results, you cannot tell if it's beta 0, beta 0, beta 0, or beta plus just by looking at the HPLC. If you really want to know if the person is beta 0 or beta plus, then you have to do sequencing, do DNA tests to tell the difference. And why would you do that? For genetic counseling reasons. So if you want to know a couple and you want to say what are the chances of you having a child with beta thal major, if you have beta 0, beta 0, both the couple has it, both the woman and the man have it. So then that's important for counseling reasons. All right. Now, one little nugget here is that in which situation the hemoglobin A2 does not elevate in beta thal trait. So I said hemoglobin A2 goes up because the delta globin retains function, but there's one situation that it doesn't. Correct. It's iron deficiency anemia. If you have iron deficiency anemia, your A2 does not increase. You have to treat iron deficiency anemia, repeat the test, and then you see the A2 elevated. All right, so now it becomes easier to interpret because the percentages follow the same pattern. Now I'll give you a little bit different mutation in the same beta globin. It's the beta C mutation. And then now, you follow the same thought process. Hemoglobin A2 won't be produced as an adult because there's no normal beta globin, but now you have A2 less than 3.5%. You have a little bit F, little bit elevated sometimes, but then you have this other hemoglobin, A2 beta C2. A2 beta C2 will be the majority of the hemoglobin. This is hemoglobin C disease or homozygous hemoglobin C disease. As a newborn, you have no A, no A2, and you have the majority of fetal hemoglobin, and now have this hemoglobin C, and the result of the newborn screening will be hemoglobin FC. And then you can mix, and then again, becomes so much easier now that you have this picture in your brain. And now you see, okay, now I have a beta C mutation, beta S, and then as an adult, no A because there's no A here. hemoglobin A2 less than 3.5. F is a little bit elevated in this case, but look at the split of beta A2, beta S2, A2, beta C2 is exactly the same, because here there's no advantage, there's no affinity, because both are mutated. Nature goes, okay, well, there's no advantage of binding with this or binding with this, so alpha will bind equally to both. So this is hemoglobin SC disease, and the newborn screening will show hemoglobin FSC, and sometimes they say FCS. It doesn't matter because these two are in the same quantity at birth. All right, so now we're gonna mix thalassemia with sickle mutation. And this now is a silenced beta globin with a beta S mutation. So now it becomes easier for us to understand. So my suggestion to you is have this diagram, this picture in your brain, and then when you see the numbers, you think back to what where the location of the mutation. So if there's no hemoglobin A, 0, and then hemoglobin A2 again, if this turns, remember, every time this doesn't produce or decrease production, then the delta turns on, so you have a little bit elevation of A2, and then you have majority S, F, and F is retained the production. So this is hemoglobin S beta 0 thalassemia. In a newborn screening, it will be FS, just like SS. So just by looking at the HPLC results, if you look at the percentage at birth, it will be FS. There will be no FS production, most fetal hemoglobin at birth, no A2 at birth. So it will be a lot of hemoglobin F and hemoglobin S. So then how can you tell? How can you tell at birth if you have SS or S beta 0? What can you do to help you differentiate? The phenotype is a little bit different later in life. S beta 0 sometimes has less complications than SS. Then you check the parents. If the parents are available, you check the parents, because one parent will have the thalassemia trait, the other will have the sickle trait, in the case S beta 0, or both will have sickle trait. This is the answer. Okay, and the other situation is you have decreased production of the beta globin rather than complete silenced. So this will be S beta plus thalassemia. There will be a little bit of A, and a little bit of A2 with a little bit of F, and the rest is S. In a newborn screening, now this is something that I'll teach my fellows, is that this is the opposite of sickle cell trait. This is FSA, more F than S, more S than A. Why more S than A? Remember, there's always the affinity. There's some normal beta being produced, so the alpha will always prefer to bind with the normal beta than the mutated beta. So there'll always be a little bit of A being produced, but there's not enough beta to bind, so the majority will be S, but there's some A. So this is not sickle cell trait. This is hemoglobin S beta thalassemia, beta plus thalassemia. This is sickle cell disease with symptoms. All right. And very briefly, alpha thalassemia. No, you see, you have alpha thalassemia too in India, but alpha thalassemia is usually a deletion, and that is more, in my mind, more mathematical, because the way to think about it, you silence one alpha globin at a time. You have 4. So let's begin now knocking 1 down at a time. Delete 1. This is 1 gene missing. This is alpha thalassemia silent carrier. This has no symptoms. And about 30% of African Americans in the United States have the silent carriers for alpha thalassemia. And then if you knock out 2 alpha genes, you can knock out on the same chromosome. So you can knock out in cis. This is alpha thalassemia trait. Or you can knock out in trans, sorry, this didn't work, both copies being non-functional. So this has implications. So for example, in the United States, about 3% of African Americans have alpha thalassemia trait, but they're all in trans deletions. So they're all in the alternate chromosomes. So that has implications, because if you have alpha thal trait, what do you see in HPLC at birth in a newborn screening? I'll talk about the implications for counseling in a little bit. Correct. So you have the presence of fast band. What's the fast band? So remember, the primary hemoglobin at birth is fetal hemoglobin. Then you have too much gamma chains to bind alpha, and they end up binding with itself. So they form this gamma 4, which is too much gamma for alpha. So they're called hemoglobin BARTs, and they run very fast on the gel. So this is the BARTs hemoglobin, or gamma 4, and you can catch those on the newborn screening. All right, so now I'm going to knock out 3 copies of the alpha gene. So now this is a problem. The trait is okay. The alpha thal trait, people have no symptoms, just a little bit, half a gram of hemoglobin drop in general. But this is a problem. This is hemoglobin H disease, because there are not enough alphas to bind the other hemoglobins. And this is what it looks like. You can catch it here on the electrophoresis, hemoglobin H. Hemoglobin H is B4, beta 4. So too much beta to bind alpha. So hemoglobin beta 4, but you also have the BARTs, the gamma 4 at birth. So at birth, you can catch it. Gamma 4, beta 4, BARTs, and hemoglobin H will be the results in the newborn screening. And then in the peripheral blood, we show target cells, microcytosis, hypochromia. Over time, people with hemoglobin H disease behave like thalassemia intermedia. And then you can do a special staining, brilliant crescent blue. Some labs still do that, and it's really pretty. Then you see the hemoglobin H that denaturates and precipitates inside the hemoglobin, inside the red cell. All right, and if you miss all 4 copies of your alpha globin, that's really a problem, because you depend them to live. That's hydrops fetalis. Incompatible with life unless you diagnose in utero and you begin intrauteral transfusions. And then in some cases now we are transplanting after birth, doing bone marrow transplant and curing hydrops fetalis. Okay, now I said the importance of the alpha thalassemia trait is for counseling. So what are the chances that an African-American couple with alpha thal trait will have a child with hydrops fetalis, with 4 gene deletion? So it's a little bit tricky. This question is 0, because that's the 3% of African-Americans have the trans deletion, and as opposed to Southeast Asian who have the cis deletion. So then what happens, the offspring of this couple will always look like them, right? They all 100% will be trans like their parents. And then there's the constant spring that it is mutation, but think it is functioning as a deletion. It's just the same thing. It's just a big alpha globin protein that doesn't work. All right. Now, one thing that I said in the beginning, the alpha and beta, the alpha always will have the preference to the affinity for beta rather than beta S. But then one interesting thing is that if you also have the alpha thalassemia with the beta S, with sickle mutation, the interpretation changes a little bit. Remember how I said, if you have sickle cell trait, the proportion of A versus S will be 60-40%. Now it will change. It will be more A, even more A than S. It will be like something like 60-20, 80-30%. That is because there's not enough alpha, so they'll prefer binding beta. So the little alpha that is produced will bind with more betas. And the newborn screening will be the same thing. So you have, instead of 6-4%, will be 7-3%. But also you have BARTs now, the fast bands. So the report will be FAS plus fast bands most of the time. So sickle cell trait with fast bands. All right. Now, another case, the third case is a 12-year-old male, healthy, found to have sickle cell disease on a newborn screen. This is to contrast with the case of the twins that I mentioned in the beginning. And the 3.2 normal weight, no transfusion history, so pretty healthy. And this is the HPLC of this person. at 12 months of age. Still a lot of F. I shouldn't have 36% of fetal hemoglobin at a year of age and had hemoglobin S. So this person had a normal hemoglobin at a year of age. I'm sorry, this was a little bit later than a year of age. This was like around teenager years. Hemoglobin of 14, reticulocytes were normal, no hemolysis, no elevation of bilirubin. So this is a little bit different than the first case that I mentioned. What do you think this person has? So this is SHPFH, different than the other case. And so this, we did do this is a real case of mine. I did do the DNA test, and this person with elevation of fetal hemoglobin has the SHPFH deletion. So hereditary persistence of fetal hemoglobin, there are two kinds. And you produce fetal hemoglobin throughout life. That's naturally occurring. It can be deletion and non-deletional. So deletional, you lose some of the genes in the beta globin cluster. So remember the gamma, delta, beta, somewhere around that you delete some of them, or non-deletion. Then now you have the mutation in the locus control region, that little piece before the gene. So this is just showing the most common kinds of hereditary persistence of fetal hemoglobin. They're HPFH1 and 2, the black and the Ghanaian. And here's where you lose in the black kind, you lose the delta and the beta, but you retain the gammas, or you can lose a little bit more. This is the pseudo beta, but you retain the gamma production. In the non-deletion, like I said, it's a mutation in the locus control region. And if you co-inherited with S, it's a very benign condition. There's no hemolysis in most cases. There's low MCV. And the fetal hemoglobin is pretty high, maintains high production throughout life. And this is what happens to the fetal hemoglobin. Of course, it drops some, but retains pretty high production throughout life, the fetal hemoglobin and the SHPFH. And this is a recent paper by Dr. Steinberg that shows why people with SPFH have no symptoms. Why do they do so well? So here's this is why, because they have a lot of fetal hemoglobin in the same quantity throughout all red cells. So they have what we call the homogeneous distribution of fetal hemoglobin. And they are normal cells, they don't sickle. As opposed to a person who has SS and takes hydroxyurea. This is a sickle cell that has very little fetal hemoglobin. So there is higher fetal hemoglobin with hydroxyurea, but it's very heterogeneous. Some cells have normal fetal hemoglobin, some cells have very little. The uneven distribution of fetal hemoglobin is the problem. And this is the case in the beginning. I'm going back now, I'm almost done. That the gamma delta beta thalassemia, the cases that I showed in the beginning, that those twins, they are not quite like hydroxyurea, but they have also uneven distribution of the fetal hemoglobin. Some cells have very little, some cells have normal fetal hemoglobin, some cells are in the middle. And then interestingly, if you do gene therapy and you make that person produce more fetal hemoglobin, that is even a different pattern here. You have most of the cells with a lot of fetal hemoglobin and a few with little fetal hemoglobin. In general, it's close to homogeneous. So with the gene therapy, you kind of copy nature in the SHPFH phenotype, but not quite. I'm going to skip this. This is back to the case in the beginning, the gamma delta beta thalassemia, very rare. It occurs in Mediterranean, Chinese, African, Indian descents, and this is the case, going back to the case in the beginning. So this is the representation of those cases. The gamma delta beta thalassemia, you lose all of this. You still have one copy of the gamma globin. And this, what as an adult, it looks like you have still production of fetal hemoglobin up to 30%. But then if you have this, with both cases, you have the homozygous and you have a lot of fetal hemoglobin, and there are rare cases with delta beta gamma thalassemia. Okay, what is the newborn screening of a person with gamma delta beta thalassemia looks a lot like thalassemia major, but we don't know in the beginning. So you refer to a treatment center and then you do DNA test to make sure that this is not major thalassemia major. This is very rare, but it does occur. And now you can mix that with sickle hemoglobin, which is what my patients had. You lose all of this, but you have the sickle hemoglobin. Now you have no A, and you have as an adult no A2 being produced, but then you have fetal hemoglobin and sickle hemoglobin. And this is what it looks like in my two patients. We did DNA testing, and and just as an illustration. So this what it goes away on my patients. So the beta, delta, gamma here, and this is just to contrast the difference with the HPL, the deletion of HPFH is larger, but retains the gamma globin, and the beta, and in the black gamma delta beta, you lose one of the gammas. Probably that's why you don't have the same kind of distribution of fetal hemoglobin. So I'm gonna, this is what the newborn screening looks like. I'm gonna copy this, and I want to show you this at the end, why you have an even distribution in this kind of mutation, the gamma delta beta thalassemia, is because the RNA production of the gamma globin, and this is up here are the gamma delta beta thalassemia versus HPFH. Here you see HPFH, you have a pretty even production of fetal hemoglobin, but then you have a variability in the production of fetal hemoglobin in the case of gamma delta beta thalassemia. This is why you don't have an even distribution of fetal hemoglobin. You have heterogeneous production because your RNA doesn't produce as robustly fetal hemoglobin as in the HPFH. So this is the reason. You have one peak here, another peak of fetal of gamma globin function, which is different than HPFH. All right, if you want more information, I recommend you reading the Barbara Bain book. It has a lot more information about it, much of what I said and more. All right, sorry it was so long. It is a lot of ground to cover, but I think we have a few minutes for questions. Thank you.
Oh, thank you so much.
I can make the slides available if it's of interest.
Brilliant, thank you. Thank you so much, Professor Hankins. I think Dr. Anita has also joined, if she has comments.
Sorry to call the time.
Yeah, thank you, Dr. Hopkins, for an excellent lecture and taking you through the journey of hemoglobinopathies, starting from the globin gene switch from embryonic to fetal to adult, then explaining about the different genes, hemoglobin production, and then mainly explaining the combination of different hemoglobinopathies. HBS beta thalassemia, HBS with HPFH, HBS with A gamma delta beta thalassemia. Excellent lecture. I just have few comments to make because the audience is mainly Indian doctors. That one of the slide which you showed of HBS with HBS beta thalassemia, you have shown HbF of 5 to 9%. Hello, can you hear me? Yeah. Hello.
Yes, madam.
Yeah. So usually, madam, as you know that we Indians have Arab Indian haplotype. Usually in Indian sicklers or HbS beta thalassemia, we get the fetal hemoglobin always more than 20% in most of the cases. Yeah. And regarding the alpha thalassemia, we have a single gene deletion is very common. So mainly hemoglobin BARDs is not been reported in our population, but we have lot of cases of HBH. And even we have lots of cases of HBFH, mainly in our population. That's where just my comments. Thank you for very much for the excellent lecture, madam.
Thank you so much, Dr. Nita. So it's really interesting. The Indian population with sickle cell disease have high fetal hemoglobin, but they still have symptoms, right? So I hear a lot of a lot of pain, crisis, acute chest, stroke. They still have symptoms. I suspect if you did the flow cytometry and measure the amount of fetal hemoglobin throughout the red cells, if you could do single cell analysis, for example, picograms will be less than 5 picograms per cell.
Correct. Yeah.
But some cells with more, I think it will be heterogeneous distribution of fetal hemoglobin. That's why you have symptoms.
Yeah, correct. Yes.
Brilliant.
I think it's open for questions.
Yeah. I don't think there are any questions. I think it was one of the finest lectures. And thank you so much, Professor Hankins, for breaking down such complex hemoglobin patterns to all the trainees who've been listening to it. I think it took us back to our basics in the most brilliant, enlightening way. It was exceptional. And thank you so much. And we would love to have your slides as well.
I will send my
as
slides.
a part of our teaching. Thank you so much, Dr. Hankins.
You're very welcome.
Thank you.
Yes.
Thank you.
Thank you very
Thank
much.
you,
Thanks
Dr.
for
Anita.
having me. Appreciate it.
Brilliant.
Thank you.
Thank you, Dr. Anita. We're looking forward to your
it was
lecture
my
too.
pleasure. Sorry, there was little problem while joining. The link was not getting connected. Sorry for that.
No problem. Thank you so much,
Bye.
Professor Hankins and Dr. Anita,
Thank
and
you.
everybody else who's joined.
Bye.
Thank you.